Hello, class. Welcome back. We are in week 8, and we're going to go over chapter 41, Introduction to Healthcare Law and Ethics. This chapter matters because coding is not just picking the code. Coding sits inside laws, payer rules, and ethics. Today, we're going to focus on how to protect patients, or protect organizations, and protect you as the coder. Here's what you should be able to do after this chapter. You're going to identify where legal directives come from and spot unethical coding behaviors very quickly. You're going to also connect fraud laws, HIPAA privacy, and compliance programs to daily workflow. Alrighty, before we dive deeper into chapter 41, I want to slow down and make sure we're speaking the same language. This slide is basically your vocabulary list for the week. And these terms show up constantly in compliance conversations, audits, denials, and even job interviews. I'm going to define each one in a way that makes it easier to remember, and I'll give you a quick real-life example so it sticks. For administrative laws, they're laws created by government agencies. Think of them as the how we apply the law rule. So Congress passes a law, and then agencies create regulations that tell healthcare organizations what they must do to comply. In healthcare, this is huge because agencies set billing rules, privacy rules, and enforcement standards. Civil law is about disputes between people or organizations, usually involving money or damages. In healthcare, civil laws come up in things like lawsuits, contract disputes, malpractice claims, and sometimes billing disputes. Coding for coverage is a huge, huge red flag. This means choosing a diagnosis or code because it pays, not because it's documented, is a huge no. That is not helping the patient. That's intentionally misrepresenting the record. If a condition isn't supported, we don't code it, period. If it wasn't documented, it wasn't done. Common law is a law that develops through court decisions over time, case law. It's not written as a statute the same way, but it becomes a standard because judges set precedents. Healthcare liability and certain privacy issues can involve common law principles depending on the situation. Covered entities are organizations that must follow HIPAA. Think of providers, health plans, and healthcare clearinghouses, and sometimes they're business associates. If you work for one of these, HIPAA is not optional, it's required. Criminal law involves crimes and actions that can lead to fines, probations, or jail time. In healthcare, criminal law can apply to intentional fraud, identity theft, or knowingly misusing patient information. Disclosure means sharing PHI outside the organization or with someone who is not part of routine internal operations. So if information goes out, that's typically a disclosure. This is where HIPAA can get very, very serious because a disclosure must be permitted, necessary, and documented correctly. Double billing is exactly what it sounds like, billing twice for the same service. Sometimes it's accidental, like a system error, duplicate charge, but if it's repeated or ignored, it becomes a huge compliance issue. Executive orders are directives issued by the president. They can shape healthcare policy, enforcement priorities, and federal agency actions. They're not laws passed by Congress, but they can still influence what agencies focus on and how programs operate. HIPAA's privacy rule is a set of rules that control how PHI can be used and disclosed. It answers questions like who can see the information, when can it be shared, and what rights does the patient have, and what happens if privacy is violated. Mutually exclusive codes are codes that shouldn't be reported together because they don't logically occur together in the same situation, or one excludes the other. This often shows up as edits. When you see this, you stop and ask, did we code something twice? Did we pick two options that can't be true? Now, on the right side of the slide, we're going to talk about PHI or protected health information. And that's any health information that can identify a patient, where it's name, date of birth, medical record number, address, even a combination of details that can identify them, plus anything about their health condition, their treatment, or payment. If it identifies them and relates to their care or payment, treat it like PHI. Release of information is the process for legally provided patient records to someone like the patient, an attorney, another provider, or insurance company based on rules and authorization requirements. ROI is very serious. It's not casual. It's formal for a reason, and there are very specific laws that, as a release of information clerk, you have to follow. Statutory laws are passed by a legislative uh, body, Congress, or state legislature. HIPAA itself is a federal statute, so statutory law is the actual law as written and passed. Supporting documentation is your best friend. It means the medical records has to justify what you coded and billed. If the record can't support it, it becomes an audit risk, even if everyone knows it happened. Documentation is what payers and regulators believe. Unbundling is reporting separate codes for services that should be grouped together under one code or payment. This is another major compliance risk area because it can inflate payment improperly. Upcoding means selecting a code that represents a higher severity, more complexity, or more expensive service than what was actually documented. Sometimes people do it intentionally. Sometimes it happens from misunderstandings. Either way, it's a huge audit trigger. Use is a HIPAA term. Use means accessing or sharing PHI within the organization for operational purposes, treatment, payment, and healthcare operations. So use is mostly internal. Disclosure is mostly external. That's a key distinction. So as we go through this chapter, every time you hear a scenario like a denial, audit, a request to code it so it pays, or someone casually sharing patient details, these terms are the lens you should use. And ask, is this allowed? Is it ethical? Is it compliant? And what do I do next? This is our first section, sources for legal guidance. Think of this as where did the rules come from map. If you know your source, you know how strong the rule is and who enforces it. All right, this slide is basically your where do I go when I'm not sure slide. Because in real coding work, you're going to hear people say things like, that's what we've always done, or I hear Medicare changed something, or compliance said we can't bill that anymore. And the key skill isn't guessing, it's knowing which source of authority to check, so your decision is defensible. Now, the Federal Register is the government's official bulletin board. When federal agencies propose new rules or finalize rules that impact healthcare, payment rules, reporting requirements, compliance updates, etc., this is where it shows up publicly. So if something changes at the federal level, the Federal Register is often where it becomes first real in writing. Coder translation, this is where big policy changes are published. And later they trickle down into payer guidance manuals and claims processing rules. Source of directives. Now, your source of directives just means who is telling you what to do and what level of authority that instruction has. A good coder will always ask, is this directive coming from law, from a regulation, from a payer policy, or from internal compliance? Or is it just a habit someone passed along? Next, we have statutory laws, and these laws are passed by a legislative body, Congress at the federal level, or state legislatures at the state level. These are the actual laws on the books. They create the foundation for everything else. HIPAA, fraud statutes, and many healthcare regulations begin here. Executive orders are issued by the president. They can direct federal agencies on priorities and action. Now, coder translation means that when you think about executive orders, you're going to think about how it can influence enforcement focus or operational shifts. But they aren't the same thing as statute passed by Congress. Still, when agency priorities shift, audits and education can shift too. Now, common laws come from court decisions, court case laws. Judges interpret and apply laws, and those interpretation becomes precedent. Why this matters to us as a coder, these matters because when you see legal disputes shaping how rules are applied, especially around liability, negligence, and sometimes privacy or documentation disputes. Administrative laws are rules that are made by government agencies. Statutes set the foundation, and agencies build the regulations and enforcement mechanisms. Criminal laws deal with acts considered crimes, things that can lead to fines, probation, or jail time. Now, for a coder, this is important because this is where intentional fraud lives. If someone knowingly submits false claims, falsifies documentation, or deliberately misrepresents services, that can cross into criminal territory. Civil laws cover disputes between parties, which usually is money damages or corrective action. So here's what I want you to remember. When you're making a coding or compliance decision, you want to be able to say, this is the authority I use, not someone told me, or this is the way it was always done, or I did a Google search and this is what Google says I'm supposed to do. This is the official source. So again, when you listen to me lecture on this chapter, think about what would stand up in a court of law. This is how I learned it, that I need to have documentation and an official source to back up what I am doing and what I am saying. And if I don't have that, I'm not going to stand up in a court of law. Um, and I risk being penalized for that. So just make sure that you always look at the official source of truth. Now we're going to shift to rules for ethical and legal coding. This is the do the work the right way section. Ethical coding means accuracy first, always supported by the record. So this is probably one of the most important slides in this entire chapter because it's the rule that protects everyone. We're talking about the patient, the provider, the organization, and absolutely you, yes, you as the coder. When we talk about supporting documentation, we're talking about proof, not assumptions, not it probably happened, or this is usually the diagnosis for this sort of case. Proof in the medical record that service was actually performed and that there was a valid reason for it. The codes that go on a claim are not just numbers. They are a statement that says this is what happened and here's why it was medically necessary. And if someone audits the claim, the payer, Medicare, Medicaid, internal compliance, etc., your documentation is what backs the statement up. So the question you should train yourself to ask before you drop a code on a claim is, if someone challenged this tomorrow, could I point to the exact spot in the chart that supports this? Two parts of support, the what and the why. The service actually performed. This means that the record shows the procedure, the treatment, the test, the visit, whatever you were coding. If you code a procedure, there should be documentation that it was performed. Procedure note, op note, progress note, imaging report, etc. That's medical necessity. Why was it done? What was the symptom, condition, diagnosis, or clinical need that supports it? This matters because payers don't just pay for things we can do, they pay for things we can justify. So remember, don't use a code on a claim without ensuring the supporting documentation is there. So this is one of those slides that helps kind of draw a line in the sand moment for coders. Because if there's one pressure point, it's in healthcare billing. It's the getting paid. And sometimes that pressure gets aimed at the coder. So let's define it. Coding for coverage means choosing diagnosis or procedure code based on what the insurance will pay instead of what the documentation truly supports. How does that resonate with you? How do you feel when I say that? Does that make you feel kind of uncomfortable? It should, because it's not it's not ethical and it's not right. You're not coding. So, if you were actually coding for coverage, you're not coding for the truth of the record, you're coding the payer's preference. Um, so it's a big deal because this is a legal statement. This is something that Um, when we submit codes, we're saying this is what happened and here's why it was necessary. If the code doesn't match the documentation, you're creating risk. You're creating an audit risk, a recoupment risk, and a compliance risk and fraud. The difference between coverage rules and coding for coverage, um, it is really important to understand. It's appropriate knowing coverage rules so you can make sure the documentation clearly supports the service. But it's not appropriate if changing the code is going to match the payer's coverage list when the chart doesn't support it. So it's super important to code for the documentation and not the coverage. Let's talk about upcoding. This is one of the fastest ways a coding department can add on an audit radar. Upcoding is when a code is reported, or a code that's reported represents a higher level of service, higher intensity, complexity, or more severe illness than what actually happened. It's not just a small mistake, it's a misrepresentation of the record, especially when it's intentional or repeated. If you're in an office or facility that insists you include codes for services that you know were not performed at that level, that's fraud. So it's important to code again what was on the documentation. Only code what the documentation supports. If the provider believes a higher level was performed, the documentation must be updated to reflect that accurately. Unbundling is another big compliance stop sign. It's one of the most common audit triggers because it directly impacts payment. So unbundling is when you code and build the individual component parts of a service, even though there's a single comprehensive code available that already includes these components. So you may have one code that encompasses everything, which would be the appropriate code, or a coder may assign four codes for the one code, which basically unbundles every single service that was included in that code. And that's very illegal. So once again, you want to ask yourself, do I look good in stripes or orange? Because that's where unbundling can get you. Something you never want to do. So for Medicare, this is basically your warning that Medicare doesn't just trust claims. Medicare runs claims through Edit. One of the biggest tools they use is a CCI or Medicare National Correct Coding Initiative Edit. Think of it as Medicare's standardized rulebook that helps identify coding conflicts, especially when codes are reported together in ways that don't make sense, they don't follow bundling rules, or it looks like they're over-reported. So, in bundling, we talked about reporting component codes when there's a comprehensive code that exists. Medicare is going to flag that really quickly. What about mutually exclusive codes? This is when two codes are not typically performed together in the same session because they contradict each other. So, if both appear on the claim, it raises the question, did someone double count? Did someone select two options that can't both be true? So again, it's important to follow the CCI edits before submitting a claim to Medicare, um, as that will help guide you with your coding best practices, and it will also flag you if you have accidentally added a code that would hit those edits. So you have to fix that before it goes out the door. Double billing is happens you when the insurance company is billed twice for a service that was provided once. Sometimes it's intentional, but honestly, many times it starts as a workflow mistake. You know, someone didn't realize the claim already went out the door, the billing system didn't show the status correctly, or the payer portal wasn't updated. Um, Here's the real takeaway. Even if it's accidental, the payer still sees it as a duplicate claim, and that creates risk. So it's important to label a tracer on a double bill. When you mark it as a tracer second submission, you're basically telling the payer that this is not a new service. This is a follow-up on a claim that we already submitted. That matters because payers process claims through automated systems. If they receive an identical claim twice with no indication it's a follow-up, it looks like you're just trying to collect twice. So this is the compliance piece. Now, the slide says double billing can constitute fraud, and that's because submitting a duplicate claim without identifying it properly can be seen as an attempt to collect an improper payment. Now, does every duplicate claim equal fraud? No, not automatically. The intent matters. But here's what matters. Patterns and controls. If an office routinely submits duplicates without tracing or labeling resubmissions, payers can treat this as a serious compliance problem. So here's a best practice process you want to internalize. You want to verify claim status first. Check your billing system, payer portal, remittance history before resubmitting. Confirm whether it's truly lost. If you resubmit it, label it correctly. Tracer, second submission, corrected claim, whatever the payer requires. You also want to document your action, date, reason for resubmission, and where you check the status. This protects you if the claim is questioned later. So important to remember that one encounter equals one complete accurate claim. You should code all conditions and complications that are relevant to that visit so the claim reflects the full clinical picture for that specific data service. What you cannot do is split one encounter across multiple claims on different days. That's not appropriate. It can look like you're trying to duplicate services. Even if the intent isn't fraud, it creates red flags, especially for double billing, and signals poor internal controls. So I love this slide because it's short, sweet, and to the point, but it's basically a career rule for coders. It's one of those, if you do nothing else, do this habits that separates solid coders from risky coders. So, as a reminder, don't code from the encounter form or Superbill alone. These forms are helpful, but they're not the source of truth. They're often checkboxes, shortcuts, or templates, and they don't always tell the full story. This matters because a super bill might list what the office intended to do or what they usually bill for, but coding requires proof. The provider note is where you find what was done, what the provider assessed, why the service was medically necessary, and any other details that change code selection. So the best habit is read the full note first, then use the encounter form as a cross-check, not your primary source. And the Office of Inspector General, or the OIG, is like a risk radar. If a service line is on the work plan, you want to really tighten your documentation, coding accuracy, and internal audits. And you want to be proactive instead of reactive. So every year the OIG comes out with a focus. So some years they may be focused on preventive care visits. Others, they might be focused on um, innovation, radiation therapy, um, certain services. And if you are an owner of one of those services, make sure that you're dotting all your I's and crossing all your T's so you don't end up on their watch list, on their radar. Now we're going to move along to the False Claims Act or FCA section. This is where wrong coding can become legal liability. This slide answers a question people love to dodge. Who's responsible for compliance with False Claims Act? The answer is simple, everyone. Everyone who is involved in the claim. It's not just the provider, not just billing, not just coder. If you touch the claim, documenting, coding, charging, submitting, or supervising the process, you're part of the chain of responsibility. So under the FCA, liability can extend to individuals and facilities involved in creating and submitting claims to government programs like Medicare or Medicaid. You can't rely on someone else. You can't rely and really you're not able to think that someone else is going to catch it or take care of it. If you see something that doesn't look supported, your job is to stop, to clarify, and escalate if needed. That's what healthcare compliance is all about. A claim is a request for payment. The definition on this slide is important because it frames why the False Claims Act matters. A claim is a demand for money or property made to the federal government or to someone handling federal funds, like a contractor or other recipient. So when we submit claims to programs like Medicare or Medicaid, we're not just billing, we're making a formal request for government money. That's why accuracy and documentation support are such a big deal. So for CMS 1500, this is used for physicians and outpatient services. So think clinics, providers' offices, and many outpatient facilities. It can be submitted on paper or electronically, but most of the time it's electronic. Now, second is a UB04. This is used for hospitals, mainly facility billing, especially inpatient and hospital outpatient billing. Again, paper exists, but electronic submission is the norm. So this is one of the most important concepts under the False Claims Act because people think FCA only applies when someone intentionally lies. But the law includes what is called a knowledge requirement, and it's broader than most people realize. The idea is this: under FCA, a person or organization could be liable not only for actually lying, but for submitting claims when they should have known better and not choose to verify. There are three levels on this slide: when they should have known better and choose not to verify, or excuse me, think of them as three ways the FCA defines knowing. The first is actual knowledge, and this is obvious. It means someone knows for a fact the information is false, yet it's still submitted anyway. Um, Second is a willful ignorance or deliberate ignorance. This is the don't ask questions because I don't want to know category. It applies to people who should know because of their role, their training, and responsibility, but they purposely avoid confirming whether the claim is accurate. Disregard of the truth or falsity. This is more like reckless indifference, an attitude of I don't care if it's wrong or right, just submit it. Its behavior shows that you're not making a reasonable effort to confirm accuracy. So why this matters? The FCA does not reward ignorance. You cannot, as a coder, protect yourself by saying, I didn't know this. If your job requires you to verify accuracy and you've ignored those warning signs, so what's a professional standard? You want to verify documentation support, follow edits, follow payer rules, and appropriately fix patterns. You don't repeat them. You want to escalate when something feels off. The QTAM provision is a concept that makes a lot of organizations take compliance seriously, and this falls under the False Claims Act. QTAM is commonly referred to as a whistleblower provision, And the main idea here is this: it allows a private individual, often an employee or someone inside the organization, to bring a lawsuit on behalf of the government when they believe the organization is submitting false claims or not complying with the law. So instead of the government having to catch everyone on its own, the law empowers insiders, people who see what's happening day to day, to report and take legal action if fraud or serious noncompliance is occurring. Now, what this means in real life: if an organization develops a pattern of improper billing, like repeatedly upcoding, unbundling, billing without documentation, or submitting claims people know are wrong, someone inside that system may report it. And that's why compliance programs exist, not to just look good, but to prevent risky billing behaviors, correct coding issues quickly when they're found, and create a culture where concerns can be raised internally before they become legal problems. For coders, this isn't about fear, it's about professional responsibility and integrity. If you notice repeated behavior that feels intentionally wrong or consistently unsupported, your role is to pause, to clarify, and escalate appropriately through the organization's compliance pathway. Next, we'll transition to HIPAA, specifically privacy. This section is about access to information with strict boundaries, and you're going to hear PHI constantly in healthcare for a reason. HIPAA's privacy rule is about balance. It ensures patient information is available to the people who need to do their job, while protecting it from people who don't have a right to access it. The goal is appropriate access, not no access. Then we have covered entities. These are organizations required to follow HIPAA: healthcare providers, plans, and clearinghouses. If you work with any of these, HIPAA applies to how you access, use, and share patient information every day. And make note, looking at your own record is against HIPAA. So some people may think, oh, well, I work in, I'm working in healthcare, and I came into the ER last night and I want to see what my test results were, or I want to see what the doctor wrote on my ER visit and see if that's finalized. Is that a good idea? No, it's not, because you are the patient. You're not accessing the chart to do your job. Now, we have seen some situations where a coder may be coming across their own record because it's coming through coding. If that happens, the appropriate scenario is to, or appropriate thing to do with that is to give it to your coding manager or give it to somebody else to code, so you're not coding your own record. But looking at a family member's record, looking at your own record when you're at that facility or doctor's office is never a good idea, and it's actually against HIPAA law. So always remember that when you go into a patient chart, you're going in to do your job. And if you're not, you're creating, you're going against HIPAA compliance, and you can get into big trouble. PHI is any health information that can identify a patient, no matter what the format: paper chart, EHR, email, screenshot, voice, etc. Use is sharing PHI within the same organization for patient care and related operations. Think about internal access between staff in the same facility. Disclosure is sharing PHI outside of your organization between separate entities or facilities, like sending records to another clinic, hospital, or payer as part of caring for the patient. Quick takeaway is use equals internal, disclosure equals external. Release of information is the patient's written permission to release their records. It's a form, and it can be paper or electronic, that must be signed before a covered entity can disclose records to someone who doesn't already have a permitted right to them. A key point to remember: no signed release of information equals no release. unless there's a specific exemption like treatment coordination or certain legal requirements. Permitted uses and disclosures. So when do you share PHI without a signed release of information? HIPAA allows certain disclosures, but only for specific reasons. If it's to the patient, patients have a right to access their own information. If it's treatment, payment, and operations or TPO, this is the everyday business of healthcare. Treatment, sharing info to care for the patient, payment, billing, eligibility, authorizations, operations, quality audits, training, internal workflows. Opportunity to agree or object is like involving a family member when the patient is present and has a chance to say yes, no. Incidental disclosures are limited, unavoidable disclosures that happen despite safeguards. Public interest, certain required reporting that could be public health, abuse or neglect, law enforcement situations under HIPAA rules. Limited data set is data shared for approved purposes with identifiers removed and proper agreements in place. The takeaways is HIPAA doesn't mean never share. It means share only when permitted and only what's needed. A compliant privacy notice must include four key things. How PHI must be used or may be used and disclosed. It's a clear description of the main categories like treatment, payment, operations, other permitted disclosures. The organization's duty to protect privacy. Basically, we're responsible for safeguarding your information. Patient rights plus how to file a complaint and a named privacy officer. So violating HIPAA is comes with civil and criminal penalties. I want you to hear this plainly. Privacy mistakes can cost money, jobs, and freedom. Most violations start small, talking in public, sharing screens, emailing the wrong place. Build habits that prevent small mistakes. There was an incident a few years ago of a St. Charles employee at one of the satellite clinics who, over the past year or two, had been looking at patient records just because. If she didn't look at them because she had to do her job, she was looking because she was nosy. She got caught. She got fined, and I believe she spent some time in jail. So, is it worth it? Just because you're bored? Maybe you've run out of things to do, or um, maybe you just think, oh, I'm just going to look just this one time, nobody's going to catch me. Don't even do it. Don't even think about it. That's one thing you want to avoid. This is where enforcement becomes coordinated, healthcare fraud and abuse control programs. You want to think detection, investigation, and action across agencies. The Health Insurance Portability and Accountability Act created the Healthcare Fraud and Abuse Control Program, or HCFACP. It's a coordinated enforcement effort led by the Attorney General and Secretary of Health and Human Services, working closely with the Office of Inspector General and other law enforcement partners. The purpose is straightforward to detect, investigate, and prevent fraud and abuse in healthcare, especially involving Medicare and Medicaid. This is one reason why compliance matters so much. Fraud and abuse enforcement is organized, funded, and active. Next, we're going to move into the Code of Ethics. This section answers, what should I do when the situation feels gray? Ethics gives you a professional standard when pressure shows up. Now, the AHIMA Code of Ethics introduces the professional ethics standards. Many of you will be held to in HIM and in coding, especially if you get your CCA, CCS, CCSP, RHIT, RHIA, any of those credentials. AHIMA is a leading professional organization for health information professionals and includes coding specialists. Their code of ethics lays out the core expectations for how we handle health information, accuracy, integrity, confidentiality, and professionalism. These principles are not optional. They guide day-to-day decisions, especially when you feel pressure to code for payment, overlook documentation issues, or share information you shouldn't be sharing. AHIMA created ethical coding standards to guide decision-making across the industry, not just for members, but for anyone doing coding work. These standards exist to support ethical and legal coding choices, reinforce integrity in reporting, and give coders a professional backbone when pressure shows up. You can point to these standards when you just need to defend doing the right thing, regardless of the facility, setting, or job title. AAP, or the American Academy of Professional Coders, also has set expectations for how coding and billing professionals should behave, especially around integrity, accuracy, and professionalism. Now let's shift to compliance programs. This is where organizations turn ethics and law into daily operations. A strong compliance program protects staff by setting clear expectations and reporting routes. A compliance plan is an organization's formal system for doing the right thing consistently. It does four big things. First, it creates policies and procedures, which are the rules. Second, it builds a structure to follow them, roles, oversight, accountability, monitors and audits to make sure it's working, checks and balances, corrects non-compliant behavior quickly when issues are found. The goal is a culture of honesty and legal compliance and actively preventing fraud, waste, and abuse by finding problems early and taking corrective action quickly. So, chapter summary. This chapter's message is simple. Your career is built on trust. Knowing your legal and ethical responsibilities protects patients, your organization, and you. HIPAA's privacy rules give you the framework for handling PHI correctly, and the ethics standards from HEMA and AAPC guide your professional judgment when situations get messy or pressure shows up. Healthcare is heavily regulated for a reason, and that's to ensure services are delivered and billed in ways that are honest, safe, and appropriate for everyone involved. Okay, have a great week. See you next. Take care. Bye-bye.